I would like to start with the very first question, because I think Gavi and UNICEF, everybody knows what it is. Whereas I think, Seppi, perhaps you tell us in some words what it is.
Thank you, and thank you for inviting us to this very important set of presentations. CEPI is a new organization. We were established in January of 2017, and we do work very closely with our partners at Gavi and UNICEF, but we have a very specific mission. We were set up to support the development of vaccines against epidemic diseases for which no vaccines currently exist. We also work very closely with WHO, which many of you will know has established something called the R&D Blueprint for Action Against Epidemic Disease, and they've identified 10 priority threat agents that don't have countermeasures available, either vaccines or therapeutics. And so we work very closely with WHO, and we have prioritized developing vaccines against diseases on that target list.
Well, then next question, how do you prioritize? Because there are a lot of diseases that do not have vaccines yet.
Well, the diseases that WHO has included on that priority list are diseases that have the potential for explosive outbreaks. They have the potential to cause loss of life, high mortality rates. They have the potential to cause disproportionate economic impact. And they went through their own prioritization process. They have 2 tiers of diseases, and the highest priority threats are those that have both high mortality, potentially highly transmissible, and that would be associated with, as I said, these disproportionate economic impacts. CEPI as an organization has secured about $800 million to support its research activities. And for those of you who know about vaccine development, $800 million, while it sounds like a lot, from a development perspective actually is not all of that much. And so we have had to actually take the WHO list and further prioritize, and we've used potential public health impact and the potential to actually develop vaccines against the targets to using those 2 criteria and looking at that in depth to identify diseases where we think we have a strong likelihood of actually succeeding, either because we have vaccines that are in the pipeline or because we understand the immune response that the disease produces in humans sufficiently to think that there's a pathway to a vaccine. I'll just say, just to quickly finish on that, so the diseases that we have prioritized are MERS, the Middle Eastern Respiratory Syndrome, Lassa fever, which is a disease of West Africa that was mentioned earlier, Nipah, a disease of South Asia, chikungunya, which is a globally distributed disease at this point. It's become essentially pandemic in many respects, and Rift Valley fever.
Thank you. And this is now your list, so your to-do list. And what does in this special list then mean equitable access for you or for CEPI?
So we've actually, CEPI, when CEPI was first established, our mission statement said that CEPI's mission was to develop vaccines against epidemic diseases. We've revised that mission statement, and that the mission statement now says that CEPI's mission is to develop vaccines against epidemic diseases and to ensure access to those vaccines for the populations that need them. And by access, we mean where price is not a barrier. And we also mean, I was struck by the presentation of the kinds of factors that contribute to no immunization or under-immunization in populations. Those happen to be the exact conditions that also give rise to epidemics. And I would say that a society is afflicted by diseases that thrive in the conditions that society creates. And we now live in a world where diseases can be transmitted rapidly, that are dominated by megacities, crowded megacities. So for us, the definition of access is operational, and it is, does a person have the ability to get the vaccine against the epidemic disease in the context of a public health emergency? And that is, I think, there are many similarities to the access challenges that have been described, but delivering vaccines in the context of a public health emergency where a vaccine may be used in a very particular way. Ring vaccination against Ebola is a very particular use of a vaccine that in many cases will not be able to depend upon traditional vaccine delivery systems. So for us, addressing access means making sure that we first have developed a vaccine, that we have a vaccine that works, that we have thought about how it could be used in the field, that we have vaccines that are appropriate for use in austere circumstances, that we have developed protocols for that use, and that we have worked with countries that are at risk for these diseases to make sure that they are ready to receive and deploy and use and deliver in the context of a public health emergency. So it's a very, maybe a more narrowly defined problem, but a problem that has end-to-end elements that we have to address in order for the vaccines that we develop to be of any real value.
Yes, thank you, I think, for making this clear difference between immunization in regular programs and immunization, vaccination in emergency situations such as we have lived through with Ebola. You have mentioned prices, and that is perhaps the moment for me to hand over to another person here on the board. Yes, perhaps you give already to Dr. Colwell. Dr. Chris Cole joins us from Merck Sharp & Dohme, MSD. He will get questions from me from all different aspects, but first of all, because Merck is well known around the world, I mean, second largest company after Pfizer now, there will be questions from my side, but first of all, what do you say about the pricing and the questions that have been risen already in the previous presentations?
First, let me say it's a real honor to be here, and actually, frankly, quite humbling with the speakers so far and the speakers presently. So thank you for having me the opportunity to be here. I'm responsible for our vaccines public policy at MSD, Merck in the US and Canada. There's another Merck in Germany. Long story there. But I guess let me approach the question a number of ways, because you asked about access, and then I will touch on the pricing more specifically. So let me first think about how we would approach access to vaccines. And I think we look at it quite broadly. So access, we have to have access at the low, middle income countries, as well as obviously we work in high income countries. So we have partners that we work with, Gavi included, to ensure that there's access to our vaccines in low income countries. So of course the different archetypes we approach it. I think access is also something that you should look at across the life course of vaccines. There's a lot of course, important and appropriate attention on pediatric vaccines, and there's generally a stronger infrastructure for pediatric vaccines, but then for adult and adolescent, it gets weaker, even in developed countries. So we think about access in terms of the spectrum of the life course. And third, I would say, we would look at access in terms of availability of the vaccines that we have today, and then also preparing for vaccines in the future, which involves, of course, investing in our pipeline as well. And we are committed to vaccines, and we do have a fairly robust pipeline. To the issue of pricing, which of course is an important one. So first we approach it by looking at the broad value of vaccines. And I could talk a little bit more about this later. But when we look at vaccines, it's generally recognized they're one of the most cost-effective interventions, I think number 2 after clean water. And that's even just looking at the direct health benefits. There's another perspective that we can explore further with vaccines, which is looking at the broad societal benefits. So not just the direct health benefits, but what are the increases to productivity? What does it mean in terms of less absences from work because of missed illnesses and cost savings? And as we heard from Dr. Gupta's conversation, really the social equity that strong vaccine programs can bring. So I think we look at it from that first looking at the broad value of vaccines. Then in terms of how we would approach our pricing, we look at it from a number of different ways. One, we look at what is the economic value of that vaccine to different economies, because different economies will have different value associated with what their circumstance is. There's going to be a higher value in a higher income country than there's going to be in a lower income country. So we look at what that economic value is. We look at what is the infrastructure that's available in that country for the deployment of vaccines. And we also look at the economic ability to pay of a country. So we do approach our vaccines through tiered pricing. You would know that phrase. And as shared earlier, the price that would be provided to a Gavi country is substantially lower than that would be provided to a high-income country. So that gives a little bit of flavor on how we view it. I hope that answers some of the question.
Yeah, I think that helps. So you go to different markets and you adapt prices. I wanted to ask you, and it has been already mentioned, that we have to support or promote or stimulate the producers of vaccines to have sufficient levels and to produce them. If we look at Merck recently, just a week ago or something new, Merck bought Peloton, which is a company that produces a renal cell cancer drug. You also have bought Viralytics, again, an oncology company. So in a company like Merck, where there is a broad portfolio, how, let's say, is vaccine positioned versus oncology?
Yeah, very good question. Well, I would say I'm very proud that at Merck, vaccines are one of our pillars. And you could go through our earnings calls and our annual reports and hear what we say, not just to these audiences, but to our investors as well. So I think I'm very proud that at Merck, vaccines is really one of our pillars. You do touch on an important point, which is that in a company, we have to manage our portfolio. So we do have a broad portfolio. And what that means, quite frankly, is that investments in vaccines do need to compete with investments outside of the vaccine space. That is a reality within a company. That is also a reality in our general ecosystem, that there does need to be a business case, quite frankly. But we see a strong business case in vaccines, and we are committed to investing in vaccines. I can share, and I'm sure we'll talk more about supply later, but I can share just recently we announced an investment of $1 billion to increase our capacity for the HPV vaccine. And there's more to come. So we are committed to it, but you do raise the point, as I said before, which is that we do need to have a perspective, and there does need to be a viability to an investment. And this is not just for MSD, this would go for any company. There needs to be that viability, that investment can compete adequately with other investment options.
Thank you, and I'll try now to get the two of you. I mean, Dr. Gupta very clearly stated that cervical cancer is a problem in low and middle income countries. It's not the problem in Switzerland or anywhere else here around. In Switzerland, the introduction of HPV vaccine took less than a year. Usually in Switzerland, the introduction of a public health measure takes about 40 to 50 years. And this came as a surprise to me. Whereas HPV vaccine is mostly needed in countries where cervical cancer is a public health problem and life-threatening to young women. So how do you see, as a producer of Gardasil, one of the two big HPV vaccines, how do you see the fact that low-income country women should have it, and it's best and, let's say, fastest introduced in those countries that won't need it so much? And I invite Dr. Gupta to enter into the discussion because you started with cervical cancer.
So first I'll say that we are committed to Gavi and the Gavi market. We've obviously had supply challenges, which I'm sure we'll talk to, but we are committed to supplying to Gavi in the low-income countries. We do have a balanced portfolio as well. We do produce and we do distribute in the high-income countries as well, where there is a high demand and there's been established programs. So when we look at our supply, we really take a balanced perspective on the markets that we serve, and we do supply to those that have established programs because it's important for us to keep the momentum of those programs. And we do also have a commitment to Gavi. We do have supply constraints, and again, I can talk more about those, in some question, which is an unfortunate reality in which we are making some investments and changes on that. Again, I'm happy when the time is right to elaborate more on that.
So I think, there are several compounding factors here. One is that there is technical guidance, by WHO that itself creates, a set of difficulties of prioritization. So, first of all, the position paper of WHO actually sort of recommended HPV for both boys and girls, right? And then recently that was revised to actually, in the past the age range was 9 to 13 years, right? And now the age range has been expanded to 45 years and recommended for both men and women, right? Mm-hmm. So really the difficulty is, as you rightly said, how do you prioritize? So, when you have expanded substantially, the target population, and then, how do you, so and particularly in a situation where there's a supply constraint, right? So the demand is jacked up, supply is low, and therefore now the question that you raised is about public health impact. What is the moral imperative here? So to me, that is the question, and I think this is time for us to seriously reflect on this, whether, and there are several actors in this space, and probably time for serious introspection.
And perhaps bold decisions.
Yeah.
I was going to talk maybe a little bit about the supply, if I can just take maybe a few moments on that. And maybe I'll provide a little bit of context of the challenges that we face, what we have done, what we're doing now, and more that can be done. So one of the challenges with vaccines is and I had the privilege of working in our vaccine engineering and operations prior to moving to public policy, so I lived and breathed this for many years. One of the challenges with vaccines is they are very complicated to produce. They are manufactured via living organisms. So unlike a chemical synthesis for a traditional pharmaceutical, which could be replicated and scaled quite relatively easily, vaccines are completely different. Being made by living materials, it's a very complex process that has a duration to it. From the time you start a bulk batch to the time you have a finished product could be 3 years, could be more. The vaccines that we make today are even more technically complicated because many of them have multiple serotypes. So what that means, if you have a 4-valent vaccine, that means you need to make 4 different bulks, and then you need to combine them. So that makes for an extensive process. The other challenge that we had is with the demand forecasting. The demand for HPV vaccine has gone up tremendously in a short period of time. To create a new facility, which we are working on now, from the time you begin to the time you have that facility constructed, validated, and producing material could itself be 4 years, it could be longer. So we are in a time period now where demand went like this, and we have a lag in producing the supply. So what are we doing about that? We are investing heavily in producing new facilities. I mentioned we announced a $1 billion investment last week or the week before. We announced previously, over the next 5 years, we'll be investing $16 billion in capital projects. Those are not just for vaccines, but a substantial amount of that will be. And we have doubled our production of vaccines over the last, I think, 5 years. I'll have to get my facts straight. But if you look at the amount of vaccines that we're producing, including HPV, the amount is significantly more than it has ever been. The challenge is that the demand has outpaced the supply, and we're working to remedy that. But we'll continue to be in a challenge situation for a couple of years. The one other thing that maybe I'll mention, if I could take a moment. Sorry, Richard.
Sorry,
Good to see you.
Good to see you.
Is that there are other opportunities that we can have to improve our supply chain. And part of this comes to, I think, regulatory harmonization. And this is probably a long topic for another day, but I think it's appropriate to give some teasers on that. When vaccines are, rightfully so, heavily regulated products, more so than pharmaceuticals, because you actually have to license not just the product, but the vaccine itself. We're subject to a number of inspections, and what we've experienced over the years is as the number of new regulatory agencies across the world have been maturing, which is a good thing. But many of them are requiring they have different sets of requirements, which means both just in the licensure, but then also through the manufacturing process, changes that you need to make, improvements that you need to make. You have to submit those to multiple regulatory authorities. There could also be different requirements based on the label of a product. I'm giving you some specific examples, which means we might be able to produce a certain amount of vaccine intended for one market, but if the demand shifts, we can't just take that vaccine and move it to another market because it's not labeled appropriately so. So there's also opportunities, we think, in better regulatory harmonization to make remove some of the constraints that we have in the supply chain. That will not take away the underlying investments which we talked about, but I think it's appropriate to pose some of those challenges and opportunities for some additional context. So thanks for that time.
Thank you and this gives me the opportunity to introduce our other panel member. Michael Moore is the past president of the World Federation, but he is also the past CEO of the Australian Public Health Association. And Michael, I know you're well known to part of the people here in the room, but perhaps not everybody knows that the Public Health Association run regular immunization conferences. And in this setting, you probably understand very well what Dr. Colwell just explained or what Dr. Gupta told us. So you have been working as the CEO of the Australian Public Health Associations with pharmaceutical industries for running the Immunization Congress and probably in other circumstances too. So, do you have any conflicts of interest there?
I think it's a really important and interesting question that we deal with conflict of interest because it's such an important good governance matter. And so many years ago, the Public Health Association of Australia developed particular protocols for dealing with immunisation companies, as we do with other companies. And the important part of that is that we've also reviewed that quite a number of times. And we work both with the immunisation companies and also in Australia with Medicines Australia, which is a coordinating body for vaccine companies, so that we're clear that we're not favouring a particular company. And more importantly, I think that we don't favour in the advertising the way we deal with it a particular product. And so the support we've had from vaccination companies is for us to run the programs as we see fit to talk about issues around vaccinations we have today. And that doesn't suit a particular company, but it suits all vaccination companies. And it's a really interesting area because we've been challenged on this quite a number of times. And I think one of my responses is to those people who say, well, actually it should be a government responsibility, it's a public health issue. But there are no governments in Australia that are going to do the sort of planning that you talk about over very long periods to develop a vaccine that might actually not work and to take those sorts of risks, because governments tend to be much more risk averse. And we also know that governments work from one election to another. They might have a longer vision, but by and large, priorities come at local elections. So we see it as an important issue to work alongside government, alongside vaccine companies, and to make sure that we can get the best possible outcome for the public's health, because that's the same priority we all share.
Yeah. Yes, and as I have you and Dr. Gupta, you both perhaps don't know that you have something in common. Dr. Gupta was working as secretary with the Ministry of Family and Health, and you have been health minister. So you both were on the political level, and we are talking about access, we are talking about the role of governments in spreading out. My question to you, Australia is a country with indigenous people. Surprisingly, the vaccination rate of Aboriginal people in Australia is high. We have also seen from data shown to us that sometimes indigenous people have higher vaccination rates. So this is very interesting, and perhaps some words about this divide, because we're talking about a lot of divides.
Yes, look, I think it's actually one of the great success stories. We often talk about disadvantage amongst Aboriginal and Torres Strait Islander people and Indigenous people worldwide, but the coordination amongst Aboriginal controlled health organisations. So what's happened in Australia is that a number of, and it was an initiative from Aboriginal people, that they wanted to take control of their health organisations, which has access by the vast majority of Aboriginal people. And by the way, they also are open to other Australians as well, and are often used by refugees and immigrants who come to Australia. But they built that relationship of trust with their people, the patients they're working with. And you know, we've heard today quite a number of times people talking about trust. And I think it's a really, really important message to come out of this conference, that we build trust, and that trust is what actually works. And I think there's a lot of lessons that in non-Indigenous Australia we can learn from these, we call them ACCHOs, these Aboriginally controlled health organisations.
Yes, so again, we can learn from what happens with Indigenous people. It is good that we have them also here. And I talked about, and we have heard from Svetlana, from you, about the different divides in access. The rural, the urban, underserved, and there is one point that particularly has been asked by one of our members who is not here but watching by live stream from the Emerald region about access for conflict areas. Yeah. What would you say about, he asked us, how could we facilitate, improve, what are lessons learned, and you have a worldwide view. What can we learn from other places, as someone of our colleagues from EMRO asking?
So I think it is hard to categorize all conflict settings in just one box, right? I think there is a lot of variety even within conflict settings. For example, if I were to take Yemen, you know, as one example, 50% of our public health infrastructure in Yemen is completely destroyed, and people have no access to services. You know, you could also have a situation in some of these countries where part of the population is in conflict with the government. There is no recognized legitimate government in some cases, at least in parts of the country, and there is a conflict between people and the government, and there are legitimacy issues. So clearly that is a very different kind of situation. And there, for example, in Yemen, what we've tried to do is really support UNICEF and other humanitarian actors who are active on the ground to make sure that whenever and wherever they can find access, they take advantage of those opportunities. And we know that some of humanitarian actors have been able to negotiate, you know, ceasefires, you know, for certain periods of time, and they use those ceasefires in order to provide the much needed immunization services. But this may not really work in some other settings, because we have seen that in some other cases, actually, some of the rebel groups have attacked immunization posts, they have attacked workers, because sometimes they think that immunization actually is a foreign agenda, right? So I think finally it boils down to trust issue. How do you establish that trust, between the government and the communities, between service providers and communities? And I think it's so important as a first step to understand who are those people on the ground who communities trust. In some cases, they could be your frontline health workers, they could be your community mobilizers, they could be volunteers that are working for Red Cross or other humanitarian organizations, they could be informal service providers who are not recognized often by the system. But I think a very careful mapping of all those people who are, and then investing in them and building their interpersonal communication skills and equipping them with necessary information and tools, to my mind, would be the way forward. Just one more reflection I would want to add, and that is that we have seen where countries are facing protracted conflict, it can result in large-scale displacement. So there is internal displacement within countries. So there are people who have been rendered homeless, and they are now living in sometimes, a lot of times actually in camps. And because there are such insanitary conditions, these populations are at high risk of diseases, including vaccine-preventable diseases. And therefore, having approaches which are flexible, which can be quickly customized and contextualized, and having that flexibility at the global level to rush support in a very swift manner really holds the key. And I'm really pleased to share with this audience that we have indeed introduced that flexibility in our policy. We call it the Fragility Emergency Refugee Policy, because we know that there is no time to lose in these kinds of situations, and we need to really, without asking too many questions or getting bogged down by procedural wrangles, really support countries, and that's how. So, and you could probably have countries where you see very strong performance, but that performance could suddenly come under threat because there's an influx of refugees. So out of 9 topmost countries which are now hosting the largest number of refugees, we have 8 that are supported by Gavi. So in case of Bangladesh, for example, we saw that in Cox's Bazar, when you had the Rohingya populations fleeing from Myanmar and streaming into Bangladesh, that added another 20% to their target population for vaccination. And that's the time when we started to see cholera outbreaks and really the threat of several other diseases. And we are happy we were able to step in, in a timely fashion in order to support some of these countries.
So I have a lot of other questions, but I would like to open up to the audience for those who have questions. And I just ask if you have specific questions now to our questions of access, equity, and making these 3 persons here really giving them the answers you ever wanted to know.
So I'm from a Chinese vaccine manufacturer, so invited by the Chinese CDC, so thank you very much. So this discussion let us know a lot of information from the market side and from the user side, so truly appreciate it. So for my discussion, I want to share some perspective from a Chinese vaccine manufacturer. So as a Chinese vaccine manufacturer, actually 10 years ago, our strategy is only focused on the Chinese market, never considered the overseas market. But nowadays, due to the Chinese government policy, and also due to we have expanded the facility of capacity, and we can produce the vaccine at an affordable price at a very huge capacity. Well, also, we are start to exploring the overseas market to see how to digest the capacity. So, but today I do not want to discuss the Gabon market because the Gabon market, the system is very mature and everything is well organized. We just process WHO pre-qualification and then can procure by UNICEF. And Gavi has done very good market shaping things. So the country I want to discuss is middle-income countries. I think the issue in middle-income countries has also been raised by the UNICEF and also Gavi today. So for the middle-income countries, so we have met a lot of issues. First of all is the regulatory issues, because in middle-income countries there's a dramatic difference in different NRAs, so different requirements. And also as a Chinese manufacturer, we cannot do like an MSD, Pfizer did to have a local office in every country. We have to rely on the local agent in each middle-income country to do registration and district.
Yeah. So what is your question?
Yeah. So I just want to ask for Gavi and UNICEF, is it possible to have some mechanism for the middle-income countries to harmonize the procurement and also the market share?
Thank you so much for the opportunity. I have more or less a comment and a question to Anuradha Gupta. The intervention we are providing. So I'm Khalid Mohammed from the International Pharmaceutical Federation. I am pharmacist by profession. Some reviews and analysis have found that pharmacists have a lot of role to play in vaccination, especially in the developing countries. So the question is, in the developing country like the African countries, for instance, there are issues or challenges, especially with respect to logistics, the cold chain of vaccine, the storage condition, and so on. Obviously, in the developed world, there are stable electricity, for instance, the storage conditions are intact. So this key challenge in the developing countries is very, very problematic. Are there any intervention among what you are doing to explore some opportunities for pharmacists? Because they are among the healthcare professionals being trusted in the community. So if that could be also available in the developing world, I think it will improve the acceptability we are talking about. So are there any intervention you are making to ensure that the pharmacists are also being encouraged in the developing world in the vaccine, so that to have the health for all we are all talking about? Thank you.
Thank you. This is Choi from International Pharmaceutical Students Federation, working as a chairperson of Asia Pacific region. So my speak includes both comment and questions. Like I want to thank for Ms. Gupta for organizing project in Gavi to help the refugees from Myanmar to Bangladesh. Actually, my colleagues in Bangladesh, our Pharmacy Students Association in Bangladesh is also cooperating with government to deliver some health services to the refugees. So I want to say we feel really grateful about it. And if I could ask you another question, I want to ask what kind of collaboration are you doing with the Bangladesh government or other healthcare workers? Thank you very much.
Very quickly, project to Global HIV Vaccine Enterprise. We have another interesting panel conversation, but we haven't talked much about innovation, which was in the title, and the role of innovation in expanding vaccination coverage and access. But innovation requires investing in research and development. And Chris Colwell, you have described some of the issues with manufacturing existing products. And again, I'm thinking in the next few years of new vaccine, what are the barriers to invest in R&D from your perspective as a pharmaceutical industry? And what can an organization like mine, which is a convening organization, an enabling organization, do to stimulate more industry investment in R&D, in innovation that at the end of the day will support expanding vaccination coverage?
I can start because even UNICEF is involved in procurement, but we are procurement on behalf of the government and not really looking at regulation and development at country level. So what we face that a lot of countries, the middle-income countries, they have the second certification of vaccines while they are WHO pre-qualified already. So, and we are trying to support these countries to harmonize their procurement, their own regulations, so that they have in place regulation that they cannot go for the second certification. That takes time. Sometimes vaccines are there, and they are keeping them and a recent example was Uzbekistan. They asked to support procurement of vaccine for meningitis and measles because they have outbreak, and vaccines were there for 4 weeks, and because they have the regulation to go to another certification and all processes, it took time to get all it was an emergency. So yeah, maybe Gavi can complement, but yeah.
So thank you. I don't think I have much to add except say yes, this indeed is an issue. Regulatory harmonization is, as was mentioned, quite a challenge, and I think that's something that needs to be addressed. And this is of course a conversation that needs to happen with each government, as has just been explained. But I'm sure with WHO, UNICEF intervening and really pushing the dialogue with countries on this, we could see some sort of progress on this issue. But agree that this is. So there were 2 or 3 quick reactions that I wanted to give around the questions that you asked. One is innovation. Of course, innovation has a very big place in Gavi's strategy and scheme of things. We have taken to scale several innovations. For example, auto-disabled syringes, right, were actually universalized by Gavi. Vaccine vial monitors, right, VVMs, were actually taken to scale by Gavi. So there's even now we encourage product innovations a lot. So we have now a new plastic tube presentation for cholera vaccine, which is lighter in weight, which takes much less cold chain capacity. And we've put in place a strategy called Vaccine Innovation Prioritization Strategy, which is an alliance-wide group which actually welcomes all innovations and then prioritizes them for a scale-up. In addition to that, we have other initiatives where we also encourage innovations in terms of service delivery. And our areas of focus are demand, data and supply chain. For example, Gavi has now started to market shape cold chain equipment, and as a result of it, we used to shape markets for vaccines, but we never did that for cold chain. But now we have what we call CCOP, the Cold Chain Equipment Optimization Platform, where we partner with UNICEF, and because we have again pooled demand from countries on cold chain and spurred innovation, we see really very exciting next generation cold chain equipments, including solar-driven equipments, which we are very hopeful would enable us to take cold chain to those areas which have no electricity or power. So really exciting. On data, several innovations, digital technologies, and temperature remote temperature monitoring, several things. Digital identities. So innovation, absolutely. We are always disruptive, but our comparative advantage is that we take innovations to scale and not just run pilots or small projects. On pharmacists, on the question around pharmacists, I think scarcity of human resources is the Achilles heel, right? We are talking about equity. And clearly we are a partner with countries, and we encourage countries to make sure that all available human resources are optimized. And we see several examples where countries are trying to move rapidly in the direction of task shifting and retooling several cadres of their allied health workforce. So like community health workers, pharmacists absolutely are a huge talent pool, and I think countries need to look at them and exploit their potential, because they are also trusted by communities, as you rightly said, they're very supportive of that. On Bangladesh, we have a long-standing partnership with Bangladesh. Bangladesh is a huge recipient of Gavi support. They also are a very high-performing country. Now on Cox's Bazar, that's a special support package that we gave to Bangladesh, and we are coordinating very closely with the government and alliance partners to make sure that vaccination services are really sort of maintained at a very high level. Of course, equity is now the challenge in Bangladesh. The remaining 3-4% children, who are not reached, and that is the focus of the national government.
Yes, perhaps for the innovation, you have to leave us. I see. Before Dr. Gupta has to leave us, I would like to thank you also very much for what you have done to close what we call the gender data gap.
Okay.
Because you've shown that you have tackled specifically saying, I need these data.
Right.
I need these data.
Right.
And
so just a quick comment on that. I think it is Melinda who said very recently that data can be sexist, right? So, and we don't have enough data around women and gender, and that in a way indicates the value that society places on women. And that's why, and it is true that as we have tried to sharpen our work around gender, we find that data around women and girls is woefully short of a requirement. Now, on access to immunization, we did initiate that attempt, and I said there were questions raised, but we thought that this data really held us in good stead. Overall, we emphasize the use of data, the collection and use of data a lot, and we think that equity puzzle can be solved only when you break data down, and you have disaggregated data sets which actually point the needle to those communities and children that we are constantly missing. Because without that analysis, we are going to just continue to go back to those 80%, 90% of children, but actually not identify and reach the missed children. On the rest of gender, when we are talking about gender-related barriers, this is more observational, and these are equity assessments which are systematically undertaken, and a lot of this data is thrown up by surveys that are done periodically by countries. But I think the challenge there is that it is dated. Sometimes countries do not undertake a household survey for 4 years or 5 years or 6 years. So that is a challenge, but that's something that we are actively partnering with countries to really improve.
so thank you very much, and I can only say it was a lot of contribution from Gavi, from you especially, and let us give you applause before you leave. I thought there was still, in the questions that we had, I think you are probably the person on innovation, and I see that Michael has...
I was going to make some comments.
I'd just like to make some comments first, because I think you'll need to respond to
yes,
my comments.
To some others.
Yeah,
yes,
so I'll just cover a couple of those issues. The first one about regulation is very interesting to me, because of course if we can get coordinated regulation, we can see everybody's a winner. But at the same time, we have to be very, very careful when we're dealing with international pharmaceutical companies, as we've learnt from international trade. So in the international trade attempts, what we see is that pharmaceutical companies attempt to try and get longer patents, and in turn this makes availability difficult. So I think that what we have to do is be very careful whenever we're dealing with changes to regulation. We as public health professionals have to be very conscious of our role in advocacy. We have to be able to build up community relationships between our different organisations, the World Federation, Gavi, the public health, the health promotion associations, the pharmaceutical associations, the full range, so that we can be careful of that. And one particular issue that was raised was a specific regulation around pharmacies, and so very recent innovation in Australia, where we've just started to introduce pharmacy. In fact, I had my flu injection a day before I came here through a pharmacy. The week before I had my boostrix, because I've got a new grandchild, with my GP, because you can't get the boostrix yet. through your pharmacy. So, and I can't see any reason why not. These things change, but what it takes is a coordinated effort from organisations to work together to get those things. And so that's not to say that we shouldn't be looking for innovation. We should, and I'm very happy for Chris to respond to those. But we also have a responsibility to be careful to watch what's happening with legislation and with regulation.
Perfect. Thank you, Michael. And thanks for the question on innovation. I'll address that quite a bit. I think we can look at, and Anuradha did a fantastic job laying out the different spectrum for innovation. I think we can look at it quite broadly. So R&D innovation. And to answer your question, having things like the VIP that she mentioned gives signals of what is the demand that's out there. What are the public health needs? That's very helpful from a manufacturer perspective to know where are the areas that we should be investing in. So having those good, the good surveillance, the good epidemiological data to indicate where those needs are, that's very important to us. Innovation can also be in manufacturing. There's new ways that you can manufacture. So we look at those as well. Innovation can be in delivery. So we talked about having different points of vaccination. It could be in the delivery devices as well. Prior to working at MSD, I worked at Becton Dickinson, which is the device manufacturer. So we actually, in that old hat, we worked with Gabi and others on some of those products that she mentioned. There can be innovation in other areas as well. We talked quite a bit about regulatory. There could be innovation in financing. Yeah. How are we going to be financing these vaccines? And particularly as we have the conversation about universal health care, this is a critical time for us to be having that conversation about how vaccines are funded in the context of universal health care. And I'll reflect back on the comments I made at the beginning about making sure that we really have that strong value story that can get embedded into the universal health care conversation. So there's a spectrum of innovation, all of which we really have opportunities that we really do need to explore. Some comments on the patent, and I'll confess I'm not an IP expert, but I'll address as best as I can. Obviously for pharmaceutical companies, patents are very important to us because we invest quite a bit, a number of years, $1 billion+ into products. We want to make sure that those products the investments are realized and that we have protection for those patents for some period of time. Vaccines actually are quite different. I can say as a policy person, we don't really talk too much about patent issues in vaccines because they're manufactured and they're licensed quite differently. So it's not quite the same issue with vaccines as it might be in other products, just because the way in which we're licensed, the way in which our patents are, it's a bit of a different story. A lot of the vaccines that are out in the market today have been in the market for quite some time. So the barrier to entry is not necessarily a patent issue, but a lot of other ecosystem issues. So maybe I'll end there.
Thank you very much. And I think you're right, innovation can happen in all different settings, and the gentleman in the beautiful dress may perhaps meet another person who has an innovation in cold chain who's sitting in the audience. I will introduce you both because people have great innovations from all different aspects of what you just mentioned, and I think that is probably that. I have to look at the time that is already overrun and at your empty stomach too, and I think...
Can I make one 30-second more comment?
You go.
Okay, I just wanted to take this opportunity because as we were talking about universal health care, and something that's going to be critically important for us to be able to do is to be able to tell our story to a broader set of stakeholders than we traditionally have. So, when we know the value of vaccines, the importance of immunization, we need to be able to communicate that not just to ministries of health and to those stakeholders. We need to be able to put our story into the language of the Ministry of Finance, of parliamentarians. It's critical that we do this because if we want to be able to have success in immunization and universal health care, we need to tell our story to the broader set of stakeholders that are setting the laws and setting the funding. So I just make that post, and I think that's something that, you know, as a whole group, academia, industry, public health, we can really collaborate in telling that story, and it's critical timing because we need to do that now as universal health care is being posted. So
I think you're sitting right to the right person because he is kind of, I would say, a professional advocate and has been working in politics. So I think what you're saying rings several bells in the ears of Michael Moore, who does advocacy in the terms as you have defined it very nicely. I think it's a good way of concluding by saying our common message about vaccination and the importance has to be told to a broader audience and in a different way. And if I may conclude like this, I thank my panelists, I thank the people who bravely sitting in the room and may have now a break, and thank you again.